Thank you very much. It's a real honor to be here. I'd like to really thank the organizers and thank the Leopoldina Institute for the opportunity to speak to you. I apologize in advance for my name. You may think I know some German, but unfortunately that's about the extent of it. So I will be speaking in English and can't have any conversations in German. I should mention I have no conflicts of interest. I am an associate editor at the Blue Journal, and I do have funding for some related research from some Canadian organizations. So in terms of looking at this, maybe not so much from the individual patient perspective, but really from the public health perspective, I've come up with 3 questions to try to answer in the next 25 minutes or so. What is the true burden of PICS? What's the impact on the health system and society that we work in? And then how can the health system itself better serve the post-ICU community? A lot to cover, and so I'm going to sort of focus on the first 2 and just touch on the last briefly. In terms of the population burden, this is a study that was led by Jack Awashna at University of Michigan that didn't look specifically at all ICU patients, but looked at a group of patients that I think we associate certainly with care in the ICU, the severe sepsis patients, and in this case looking in older Americans. And there's this very striking figure in the paper where we found that the green line there is the incidence of AMI and the spending associated in the hospital on AMI patients. And then that blue line is the severe sepsis patients over time. And this only goes out to 2008. And you can see the associated spending there as well. So it's pretty striking that we started out sort of on par with AMI as an issue. And then over time, there's probably some bias in terms of just better identification of these patients, but also an increasing burden of patients, certainly with severe sepsis and other types of critical illness, and in terms of where we're spending our money in the hospital, an increase. Along with that, we're getting better, at least for some of the diseases we care for, in terms of mortality for our patients in the ICU. And so not surprisingly, this black line is the number of 3-year survivors at each year that we looked at, and the gray line's number of 5-year survivors. That too is going up over time. So we're creating more survivors of critical illness, or in this case, severe sepsis. Obviously, this is a good thing, but certainly brings up all the issues that were alluded to in terms of what are the actual outcomes for our survivors. So what are the problems? Well, they were talked about in detail in the last session, so I'm not going to go over them, but this is just a list of some of the things that we worry about, certainly in our patients after intensive care. If you don't like the term PICS, you can partially blame me. I was part of the task force at SCCM that came up with this back in 2012. And as Nathan alluded to, the goal really was to allow us to start discussion outside of the ICU with other care providers, to have a way to really say, these are things that you should be worried about. And up until that point, we didn't really have a way to describe that other than things that happen to our patients after intensive care, long-term outcomes, kind of vague terms. So that was really the motivation for coming up with the term, and we recognize that it might get refined over time. This is from the original paper, just sort of showing you the diagram and the way it was thought about in terms of breaking it down into these potential areas of mental health, cognitive impairment, and physical impairments, recognizing that, as nicely shown, that they may or may not be all there in the same person, and then PICS family, which again we won't be discussing. So what does this look like? Well, I do want to mention Ramona Hopkins, who was one of the earliest people to really focus on this area, and this is one of the earlier studies that was done looking at ARDS patients, 2-year cognitive, emotional, and quality of life outcomes. And this is in that paper, and that top line there is the normal population, and these are just different domains of function there on the x-axis. And at 2 years for this cohort of ARDS survivors, the average certainly was decreased across the board. And of course, this has been recapitulated now many times, many different studies, as I'm sure you well know. Oops. However, I think we need to be careful to extrapolating to the entire ICU population for a couple of reasons in terms of thinking about this at the population level. Mostly, these are smaller cohort studies, and they are often looking at our sickest patients. And so when we're talking population level, we do have to be careful that we don't use the term ARDS then, say, to refer to all ICU patients. We also have to look at the issue of attributing the outcomes we're seeing after intensive care to the critical illness itself versus chronic diseases or even just the hospitalization itself. And I'll show you some of the data to suggest that how important this is in terms of quantifying the burden at the population level. This is a study we just published. We are interested in the relationship between time spent in the ICU and long-term mortality. This uses Medicare data, which covers about 80% of patients in the US over the age of 65, so it's pretty comprehensive in that regard. And before we even looked at long-term outcomes, we said, well, how long are people staying in the ICU in the US? And what we found here, those gray bars are showing you that almost 90% of patients who we call critically ill patients just because they pass through the doors of an ICU are only staying 1 to 6 days in the ICU. And when we get out to that 2-week to 3-week group or more, in fact, at least in the US, this is about less than 5% of the ICU cohort. Now, why does it feel like those are the patients that we're always caring for? Well, of course, they're the ones in the bed for longer. And so that black line is showing you the number of ICU bed days taken up by these individuals divided by how long they're in the ICU. These are the patients we get to know. These are the patients we're really caring about on a day-to-day basis because they're not cycling through the ICU. But I think at the population level, this helps to put back in perspective that this is a small portion of our ICU cohort. It's also important to know where you're starting from. This is my favorite title of all time from a research article, Hospitalization-Associated Disability. She was probably able to ambulate, but I'm not sure. And I think we've all been there at the bedside when suddenly someone says, well, did she have leg weakness before this? Could she walk? And you suddenly realize that you don't, in fact, know the status of this person from before they rolled through the ICU doors. And we're getting better at this. I would say we're definitely improving in our recognition that we need to understand where they're starting from. But I know we've all had that embarrassing moment of flipping through the chart, trying desperately to figure out if someone's documented this. And I think that this is a real issue in terms of if you're going to say this person's disabled after intensive care, you certainly want to know whether they were disabled before they got to the ICU. Probably the most impressive example of this is work, again, by Jack Awashna, looking at depression after severe sepsis. This is an elderly patient, a couple thousand patients admitted to the ICU with severe sepsis, quantifying over the years after hospitalization in this cohort depression, point prevalence there of about 30% after intensive care. It's worrisome, it's incredibly striking, but it's a little less concerning when you see the pre-hospitalization data and recognize that this is a group of patients who actually, a lot of them are coming into the ICU or into the hospital with severe sepsis already with depression. Now, that is not to minimize that there certainly is a step up there around the time of critical illness, and so certainly there's a signal for a relationship between critical illness and depression, but it's not necessarily that whole 30% we would have suspected if we didn't have that pre-hospitalization data. See if I can, I've just lost my clicker. There we go. Okay, great. Similarly, along with the data on depression, has been work on functional, long-term cognitive impairment, obviously something that was discussed in detail, a real concern of patients. And this is, again, work from the Michigan group looking at cognitive impairment. This paper is now from 2010, so almost 7 years old. And they certainly found an increase looking before and after sepsis in the rates of mild and moderate to severe cognitive impairment in this cohort, suggesting there is a real signal for a change in the risk associated with having been hospitalized with severe sepsis. However, I do think it's also important to actually quantify this in real terms if we're thinking population level, that in elderly ICU or severe sepsis survivors, that in fact this is about a 10% increase. It's not necessarily as impressive if you just glance at it and see these big bars, right? So very real, very much a concern for the individuals having this, but it's not an enormous number of the patients who are coming in and out of the hospital when you think about it in terms of the population level. We similarly did some work looking at diagnoses of dementia after critical illness, something that I think worries all of us, worries patients. You know, is your grandmother going to now be demented after having been through weeks in the ICU? Again, this is using Medicare data in the US, and you can certainly see, again, there is a real signal for an increased risk in the 3 years following critical illness here of the intensive care cohort of receiving a diagnosis of dementia. Now, this does not capture cognitive impairment. This is people who literally in their charts were getting a diagnosis of dementia. The hazard ratio is also pretty impressive. It is a real risk there. But I think in terms of absolute numbers, it's a little more reassuring in that, you know, elderly people, even when they haven't been in the ICU, have a 12% risk, at least in our population in the US, over 3 years of receiving a diagnosis of dementia. And that does go up, but it goes up by about 3%. So again, a real concern for that 3%, but it's not everybody who's coming into our ICU who is being exposed to sedation and mechanical ventilation. An interesting point about comorbidities, this is recent work published by a Scottish group led by Naz Lone, looking at the entire Scottish population and their admissions to intensive care. And what he was interested in was looking at hospital costs per year after intensive care for survivors. So that's what's there on the y-axis, and time is on the x-axis. And stratified by whether or not people had comorbidities coming into the ICU. You can see there on your right that if you had comorbidities coming in, your hospital utilization and costs of care after intensive care actually look like similar controls who also have comorbidity, suggesting that a lot of their issues and utilization of healthcare resources is more related to their comorbidities than to the critical illness itself. And where you see the signal for an increasing sort of risk of healthcare needs is in the no comorbidity group. And I think that sort of makes sense. The people who are coming in who are young, who don't generally get hospitalized on a regular basis, who now suddenly have been through a horrific critical illness, and relative to their peers, they are then in need of increased resource use and healthcare needs afterwards. The other point is that this is not unique to ICU patients, and I think it's really important that we're beginning to try to tease apart how much of this is intensive care, critical illness, and how much of this is hospitalization. And if you talk to those who work on the wards, they're familiar with the concept of a post-hospital syndrome. Very similar, the idea of an acquired, in this case they say transient, condition of generalized risk, where those patients can just be weak from having been hospitalized. And so as we think about what we can do specifically in the ICU ultimately to affect patient outcomes, I think it is important to tease that apart and recognize that it's not just us, maybe make us feel a little bit better. As an example of that, this is work from Denmark, where we again looked at patients before and after intensive care, and we were interested in new psychiatric diagnoses associated with having been admitted to an ICU. And this is some unpublished work that sort of rejiggered from a paper we published, looking at the psychiatric diagnoses compared to matched hospital controls, age and sex matched, and then general population controls. And you can see there is this uptick. It is substantial, and it does seem to be related to being admitted to an ICU, and that uptick is larger than the hospitalization increase you're seeing. But it is important to recognize that you do see that blue line there. That's hospitalized patients and their risk of a new diagnosis of a psychiatric illness around the time of hospitalization, and it too is increased. So some of that signal certainly is not due specifically to critical illness. Okay, what about the public health impact then, in terms, I've talked a little bit about sort of trying to quantify that risk. Well, one thing we have discovered is that rehospitalizations are common. This is work using New York State discharge data that we published last year, so it's everybody admitted to an ICU in New York State. And what we found was, following people out 180 days after discharge from the hospital, was that there was about a 25% risk by 30 days of being readmitted to the hospital. And what you see stratified here is on the bottom, that line is no mechanical ventilation. The middle line is mechanical ventilation without tracheostomy, and that top line is with tracheostomy. Not surprisingly, kind of patients we consider higher risk sicker are a higher risk for having a repeat hospitalization. And out to 180 days, almost half the cohort has been rehospitalized at some point. So in terms of the public health impact, rehospitalizations and having these patients sort of cycle back through the system is a real concern. Now that said, it is also important to recognize that cohort studies of individual diseases such as congestive heart failure look similar in terms of their readmission rate to hospitals, at least in the US. And so that this is, again, not unique to intensive care, but certainly some of our patients, the tracheostomy patients and others, do look like they're higher risk than most. There's also a fascinating kind of age paradox in terms of the public health risks and impact of our patients in the ICU. So fewer younger patients get critically ill. Overall, they have a better chance of recovery if younger, both in terms of their time in the ICU and then afterwards. Yet there is a greater impact relative to their peers of critical illness if they are younger. And this goes along with that comorbidity piece. And it's from looking at the same study of Scottish individuals, you can see again this fascinating split where if you're over the age of 70, and I'm not quite sure why they chose 70 as elderly, but that was their choice in this study, that compared to similar people of the same age, their healthcare resource utilization in terms of hospital costs looks the same. But if you go less than age 70, that's again where you see this split, where we're really seeing an impact on the healthcare system of having been admitted to an ICU relative to peers of the same age and sex. Return to work was actually discussed a little bit in terms of interviews with individual patients. In terms of maybe not the healthcare system, but society, this is a major concern. What is the impact of critical illness on people's ability to return to work and to contribute again to society in that way? This is work from Margaret Herridge's original cohort study of ARDS survivors. Again, want to point out this is a very sick cohort relative to your average ICU patient. But she found a very striking result, which was that of the people who were assessed at 12 months, only 49% had been able to return to work at all. Kind of 50, so we're at the 50% mark in terms of this cohort. And this has been kind of recapitulated in a more recent study, single center, from, I think this is from Sweden, that followed patients out, not just ARDS survivors, but those who'd been in the ICU. And they found, and the nice part about this is they have pre-ICU data, right? We know pretty easily whether people were working or students or unemployed. 63% were either working or students. Of course, there's many retired people who end up in the ICU as well. And post-ICU, that number had almost halved. So very similar to Margaret Herridge's findings that many of our patients are unable to go back to work in a meaningful capacity even by 1 year after critical illness. And this does have large societal implications. So finally, can we alter the trajectory of our patients? And I think that's what everybody is wrestling with, not only what is the burden in our society and to the health system, but how can we actually improve things? Follow-up clinics have been discussed a lot over the last number of years as a way for us to really intervene and help our patients. Perhaps the best study of this was the practical study done back in 2009 of nurse-led follow-up clinics. This was done in Scotland. Really nice study where they randomized people to get follow-up care being seen in these clinics versus not. They had set in place referral systems for if patients needed to be referred for psychiatric follow-up or physical therapy. And unfortunately, it was a negative study. And I think there's been a lot of discussion about why is this negative? It sort of feels so right that this should help our patients. Brian Cuthbertson, who's the first author, is actually in my department, and I like to joke with him that if you ask older Scottish men if they're depressed, that you're really just going to get nowhere. There's a cultural component here that's a problem. But besides that, I think one of the major issues here is that they were inclusive. They took all comers. And going back to the point that Nathan made at the end, and also that I think I've been making, is that not all of our patients need our help. There really is a smaller subset of patients who are the high-risk patients. And so if you take all comers, you're going to get a negative signal. The patients you might be able to help are going to be diluted out by all the patients who actually are doing just fine without this sort of specific follow-up. And I think the way to get at that going forward is really the work that's now being done, really trying to tease apart what is it that's kind of unique or different about our ICU patients, the ones who are having trouble. This was alluded to already, the brain ICU study, and this was a follow-up paper where they looked at depression, post-traumatic stress disorder, and functional disability. And one of their findings was not just, how many people have these things, but really interesting conclusions about the patients who scored highly for depression, which was that the somatic score, there's multiple components to these depression scores, the somatic score, the physical components were the things that people were scoring highly on, suggesting that this sort of labeling all of these patients as having depression and trying to help them through, say, psychiatric care may not actually be the most appropriate route to help these individuals. That if you tease that apart, and one of their conclusions was that suggesting approaches targeting physical rather than cognitive causes could benefit patients leaving critical care. So understanding those nuances about what it is our patients need and not just giving them a label of depression and sending them off to a psychiatrist may ultimately be the way we're able at a societal level to kind of help these individuals. I also think it's important that we don't reinvent the wheel. Again, I think ICU clinics can be incredibly helpful for us as physicians and as researchers to understand what our patients are experiencing after they leave the ICU, to get that feedback, as we just heard, incredibly valuable for all of us. But in terms of best ways for a healthcare system to potentially help these individuals, it may or may not be the best approach. And I would argue, and this goes back to really why we came up with the term PICS, it's the idea of partnering. There are CHF clinics, there are oncology clinics, there are COPD clinics. Many of our patients, particularly the ones who come in with chronic diseases, will be seen by people who know them in many ways much better than us at these clinics. And so it may be that for many individuals, our best approach at a sort of public health level is to try to get that education out there and to partner with our colleagues who care for these patients more regularly to help them, to help these patients, and maybe do some of that screening in these clinics where they're going to be seen anyway. So I think it's going to be sort of a combination going forward, but this may be one approach to the issue of resources. We have limited resources, limited ability to set up clinics in many countries, and yet I think we can still help many of these patients. Finally, just some recent work that's actually in press where we were interested in that issue of rehospitalizations and can we improve our system in terms of our care for these patients. And this is US data looking at whether or not patients ended up being rehospitalized at a same or a different hospital from where they were critically ill. And what we found was about 25% of patients, 30% of patients, were rehospitalized at a different hospital within 30 days of where they had been discharged from after critical illness. Real potential for discontinuity of care there. And in fact, we did find a signal for an increased risk of death for the patients who were getting readmitted to a different hospital, suggesting little things such as, discharge planning, where you say if you have a problem, come back here, may be really important, at least in the American system. I can't speak for Germany, in terms of ensuring that we maybe reduce this sort of duplication of services, trying to figure out what's happened to someone, and at the end of the day, improving their outcomes and being able to help them, having understood what they've already been through. So I'm going to stop there. I think PICS is absolutely real for many, many individuals, as we heard today. The size of the effect at the population level and thinking about it in terms of public health issues is still somewhat unclear, and many of the ongoing studies will help to elucidate that. We do need to be careful that we're assuming a problem is related to time spent in the ICU, and I think really once we can figure out what are the things we do and who are the patients at risk in terms of the critical illness and that component, we'll be better placed to help people. Finding ways to target the patients at risk, and there is clearly a public health impact, and that one may be large, certainly in terms of resources, but also in terms of lost productivity of our individual patients. Every time I give a talk on post-intensive care syndrome, I do like to show this image. This was by Gary Black, who's an artist who actually participated as part of the PICS task force, and he was in the ICU with septic shock for a few weeks, and he drew this picture of how he felt when he got home and the kind of incredible, literally shattered feeling he had of his experience, and it took him a long time to get over that. And I think it's incredibly powerful. I show this to my trainees whenever we talk about this to try to remind them that it doesn't end for patients at the door of the ICU. Thank you very much.
Thank you very much, Anna. Let me remind you that although Anna has said that she doesn't understand German, we have methods to make her understand it immediately. So if you would like to ask the question in German, you are very welcome. Any questions from the audience? Yes, please.
Hi, Hannah. Excellent talk. Can you tell us a little bit more on the documentation quality of the Medicare? Because I'm not so clearly convinced that all these routine data are so easily translated. Because what we've seen, at least in our settings, is that half of our patients who underwent surgery couldn't even give informed consent if we really check them for cognitive impairments at some certain level of age. So there are also studies around that.
Right, well, I think this is why it's important to have both the smaller, more in-depth cohort studies where we're able to do that level of cognitive testing that gets at many of those more subtle issues. If you look, we were very careful in our paper about dementia, for instance, to describe it as this is a diagnosis of dementia, as opposed to saying these are the patients who have dementia, because those are two different things. I would argue certainly getting a diagnosis is a big moment for patients and families, so is important in that regard. But you're certainly right that the overall burden is not going to be limited to the patients we were able to identify. And I think we just have to start cobbling together all of the different studies we have, the different populations, the different follow-up periods to try to really estimate. Obviously, I didn't give you a lot of numbers in terms of what is the kind of burden at the public health level, because I think we're still not really there. I do think it is important not to just extrapolate work by someone like Margaret Herridge, this really important work looking at ARDS, young ARDS survivors who spent, weeks in the ICU, and say these are all ICU patients. Because our ICU patients, as one of our patients here today alluded to, it is a really heterogeneous group, and that's been our struggle, I think, as a kind of society, is to figure out how do we study these patients, what's common about them, but also when do we have to pull apart the differences. And certainly cognitive impairment absolutely falls in that category.
Any other question? You were talking about patients that we look at them now, how they were before the admission to the ICU, and we often use it as some sort of indication about the near future, and that's something that we also do. It's quite often asked whether the patient was on the bicycle or couldn't move or whatever. But once you are struck with a very severe sepsis, do you think that this is still a norm which would be, people who are in a fragile age can be completely different after a couple of days of severe sepsis or any other disease. So how trustable is this actually?
I think that goes back to a lot of Nathan's data on frailty and how it interacts with critical illness that we're again just starting to pull apart. I think it is always relevant in discussions with families to know, where were they starting from. I certainly have those conversations where I say, you're describing someone who's very frail to start with. Let's now talk about what the fact that they're in septic shock might do to them and whether or not they'd even be able to get back to where they were. And so I do think as we get better at measuring frailty and understanding what trajectory patients were on before ICU, it's relevant for both short-term and long-term outcome discussions. At the individual level, of course, at some level, all bets are always off. We're not great at predicting what any individual will do, but I think that I would guess in the next 5-10 years, we're going to be talking a lot more about frailty and how that's going to modulate our understanding of how patients can tolerate critical illness.
Anna, do you think that different healthcare system could have an effect? Because most of your data comes from North America, and I think it's time to collect globally this information, because probably also the system of care, the families, the environment could have an effect on the rehabilitation of the post-intensive care phase. And I think it's time to think about globally.
Absolutely, and I sort of apologize for the fact that so much of the data I've presented is mostly US, in fact, which is a very distinctive, unique system. We've actually, it's still in the process of being written up, but compared rehospitalizations in Canada and the US after critical illness, and we have found a much lower rate of rehospitalizations in Canada compared to the United States. So a lot of these data come with that caveat that it is a very distinctive system. That said, I think we all agree that many of the issues that our patients face do seem to be pretty universal, whether or not we're caring for people in their homes. I know a lot of the Scandinavian countries have a lot more home care and options for that, or whether they're being cared for in nursing facilities, as they often are in the US. I think that the individual cognitive dysfunction, physical dysfunction is always there.
Okay, the last question from there.
Following on with what was discussed about post-intensive care in that phase, in Germany we have a discussion around the role of primary care, of family medicine, and studies being conducted, but probably with little effect. I was wondering about your own view regarding the role of a primary care system leading post-intensive care as opposed to a specialized way of
I
doing
think it would be great. One of the things that frustrated us with the PICS task force was we struggled to engage, in the United States at least, our general practitioner and internal medicine community who, I think are only starting to wake up to the fact that so many of their patients are cycling through intensive care. That was really our goal, was to say we need to partner with those individuals who are going to be seeing these patients throughout the continuum of their life. And they are, in many ways, they already have referral systems and networks in place for patients. They screen for depression, they screen for physical impairment for other reasons, and that in that sense that they are best positioned to be helping us. But we need to find a way to better engage them and to make them aware of our concerns specifically for our patients right after critical illness, so that they are heavily involved. Again, I think it depends on the system you're in. Some systems do have a more solid sort of GP system than others. The United States is very challenging in that regard because it's so fragmented.
Thank you.
Thank you.
Thank you very much.
Thank you very much, Anna.